I'm just delighted to be here at what is allegedly the North Dakota Rural and Public Health Conference. I say allegedly because I think that that's the way it was somehow pitched, but this clearly cannot be it. It can't be it because there are no blizzards outside, there's no flooding outside, I don't see any swarms of locusts or the plague or anything else, which frequently accompanied the Dakota Rural and Public Health Conference. So it's really hard for me to believe that we're all here and it's a beautiful day and travel is easy, sun is shining. It's a nice change actually, and congratulations to all of you for probably making the shift to get the conference scheduled at a time other than when those kinds of climate activities were underway. It's historically a conference that's been marked, some would say marred, by what's been going on in terms of weather, so probably this was a good shift and you did it without any direction from me, I'm sorry to say. I was probably hanging on tight-fisted to that old schedule. But it's very nice to be back in North Dakota. I'm actually here, I came home on personal leave for the Memorial Day weekend, and then when this invitation came through, just decided to do some telework from North Dakota, and then I'll of course be heading back. But it's really nice to be here among friends and colleagues, especially at this conference. It's a conference that I've always thought is extremely important. I've highly valued it when I was here, and I'm delighted and feel quite privileged to be able to be here and have a chance to talk with you about some of what we're engaged in Washington. I also want to do a quick shout out, because I'll be here just for my remarks, but I want to shout out to one of my colleagues, a colleague associated with the Health Resources and Services Administration, and that's Nick Zucconi. Nick, would you stand so that folks see you? So Nick is our Deputy Regional Administrator at HRSA's Denver office. He's one of HRSA's great team that fans out across the United States. We have 10 regional offices, not just the folks inside the DC Beltway, if you will, but we also have staff in our 10 regional offices for HHS. Of course, North Dakota is in the Denver region, and so Nick is a key contact, point of contact for you. And any kind of follow-up or questions that you have either today or at another time, be sure to get his business card. He's not the only one in that office. He has other colleagues as well, but it's another way that you can get more information about any of the topics I'm talking about this afternoon, or that I neglect to talk about and that you'd like to raise with Nick. So thanks, Nick, for being here. I also just wanted to say, by way of background, that a lot of what I'm able to execute through my position in Washington is because of what I've learned here in North Dakota, and I've learned from, frankly, many of you in this room. A lot of information that's been shared with me, a lot of the education that I've gotten, particularly about rural health and about public health, has really come from the experts that are seated in this room right now. And so I wanted to just say, by way of starting, a big thank you to each of you, because rural health is very much front and center of virtually everything that I do and think about, even though HRSA, of course, has a much broader portfolio. But there's really nothing that, that I'm engaged in where I'm not always thinking about the particular rural lens that might be applied to a program, a policy, or a particular issue. And I'm able to do that, as I said, because of the expertise that so many of you here have shared with me. You can't come out of a region like this in the United States without having some fair appreciation for the challenges that people face, both healthcare providers and rural communities, people who are living in some of our rural communities in terms of access to health care. And so, again, you can rest assured that a lot of what I'm able to do, I'm doing based on my interactions with many of you, and for that, as I said, I'm most appreciative. Today I'm going to spend most of my time talking about what I was asked to speak to, believe it or not, I'll stay on message, Lynette, which is very much the work that's underway right now through HRSA and other parts of HHS associated with the Affordable Care Act. So that's the tour, the virtual tour I'm going to take you through this afternoon. And while I'm talking talking about a particular program or initiative. If it doesn't suit your fancy, hang on, because probably 30 seconds later I'm going to be switching to something else that might be of interest and relevance to you. So it really is a virtual tour through a number of the different provisions, though by a long shot, not all of them. And hopefully we'll have a little bit of an opportunity for conversation after my remarks about anything that I might not have touched on or about which I may not have been clear enough. So feel free to be thinking about those kinds of comments or questions even starting now. But as I said, most of what I'll be talking about is the Affordable Care Act. Before I do that though, let me just tell you, for those of you that aren't familiar with the Health Resources and Services Administration, just a word about it so that you can be aware of how and when you might want to engage with this part of HHS. This part of the department that I happen to lead may well have other vehicles and programs that are of interest to you beyond what I'll be talking about with the Affordable Care Act. So a quick 30 seconds about HRSA. First of all, this is of course one of the operating divisions of HHS, not unlike CDC or NIH, FDA, and other operating divisions. We're sort of there on the organizational chart. HRSA's budget is a budget of about $8.2 billion. So it's a fairly large agency. People aren't aware of that. They've been kind of under the radar screen for a long time, but it's fairly large, both in terms of portfolio of programs. We have about 84, 85 programs that we operate, and a pretty substantial budget. Really, everything that we do, virtually everything that we do through HRSA is done through partnership. There is not a regulation I can think about, and we have actually fairly few of those, or a program, a grant initiative, almost nothing I can imagine that we do solo, that we do that is not also done in partnership with other organizational entities. To deliver services and to execute the work of the programs that HRSA operates, we have about 3,000 or so partners. And those partners include state and local government agencies, nonprofits, community-based organizations, providers of clinical services, foundations, research centers, and others. Everything we do is really in partnership. We engage a number of different programs using those partnerships. Let me just tick off a few of them for you. The funding, for example, that comes into North Dakota and every other state to support maternal child health, the maternal child health block grants, are based out of HRSA. The Poison Control Centers, the closest one here for you is in Minneapolis. We've got a Poison Control Center shield, if you will, that really covers the United States and the associated territories. That's a HRSA program. We, of course, operate the Raw and White program that provides healthcare services for patients that live with, for people who live with HIV and AIDS. Some of those resources go locally, right here to Grand Forks, and also to state government and so on. So on every one of these programs, really some resources, some benefits from the various programs accrue here in this state and then of course across the region. HRSA also has responsibility for oversight of the organ donation and transplant program. And for those of you that missed it, and for the one of you that's over 50 in this room right now, you may have seen that just last month we did a push out to encourage organ donation for people who are over the age of 50. Yes, you can donate if you're over the age of 50. This might come as a surprise to you. How old do you think, rhetorical question, how old do you think our oldest donor of an organ has been, let's say within the last 2.5 years? The oldest organ donor. Rhetorical questions, well, I'll answer it for you. 92. 92, just a few days shy of his 93rd birthday. So our push last month was really to encourage donation. 90 is the new 50. A 92-year-old, well, that might be a bit of a stretch, I know. But believe you me, the closer I get to 90 and the farther away from 50, it's all making sense for me. But the point that I wanted to make is that a healthy 80, 85-year-old, 70-year-old versus a far less healthy 30-year-old, the former might be a much better donor than the latter. So all by way of saying organ donation, big issue for us at HRSA because we manage that program. Virtually all of the workforce programs except for graduate medical education, in fact we actually do have two graduate med ed programs, but the bulk of those come out of CMS. So all of the other workforce programs for nursing, education, psychology, etc., basically are operated through and out of the Health Resources and Services Administration, and of course the Federal Office of Rural Health, which is the sharp end of all things rural from the U.S. Department of Health and Human Services, and an organization that would be familiar to many of you. So that just gives you a fast rundown of some of what we do, the resources that we have to do that work. There are many other programs I didn't mention, but it gives you at least a bit of a flavor. The focus for us is, of course, on ensuring access to healthcare services for vulnerable populations. They may be geographically vulnerable, so rural. They may be economically vulnerable, so people with very low incomes that participate in our programs. They may be medically vulnerable, so think HIV/AIDS, or think in need of a heart or a liver, and so on. So that's sort of the mission, if you will, of this particular operating division. But within that mission, of course, we also back into the U.S. Department of Health and Human Services, which has a few key aims. HHS focuses on strengthening healthcare. It focuses on advancing scientific knowledge and innovation. And HHS, our parent organization, focuses on improving the health and safety of populations across the country. And with this focus for the U.S. Department of Health and Human Services, from my vantage point, it has been particularly helpful to have our Secretary Kathleen Sebelius, in that lead position for HHS, because one of her filters also is a rural filter. And that wouldn't come as any surprise probably to any of you, because of course she was a governor of a rural state. You can imagine if you pulled a governor out of North Dakota and asked them to serve in that capacity. It's also true of pulling a governor out of the state of Kansas and asking them to serve as a secretary for HHS. They bring with them a lot of rural experience, an understanding, if you will, of some of the challenges that rural communities face in terms of access to health care, broader economic vitality for rural communities, and so on. So as former governor, she's quite familiar with health care challenges that face rural Americans, including issues around high rates of poverty, lower rates of health insurance coverage, greater numbers of people with health problems and chronic diseases that range from obesity to cancer to diabetes, and so on. And I can tell you right off, there's hardly a meeting that I'm in with the secretary where she isn't asking. It's a little bit of it's kind of sort of gotten to be a bit of a joke. Sort of who jumps in first? I, of course, am quite deferential, so I do not jump in first when she's in the room. But who jumps in first on a rural to raise a rural point about whatever issue we might be discussing? She frequently is inquiring about rural impact or rural needs as we're talking about issues. So that just gives you a little bit of an insight, if you will, into HRSA and our focus as an agency, and also that world in which we operate, the U.S. Department of Health and Human Services. With that, let me turn to the Affordable Care Act and tell you a little bit about what we're involved with. Not just what HRSA is involved with, though to tell you the truth, we are responsible for implementing 63 provisions, either leading them or co-leading them for the Affordable Care Act. CMS, Centers for Medicare and Medicaid Services, has the largest number of provisions of any operating division of HHS, responsible for implementing the largest number of provisions. But after CMS, who's next? HRSA. So we've got the second largest portfolio of activities that are underway. And in a few minutes, I'm going to share with you some of HRSA's particular activities. But before I go there, I want to step back and give you a little bit of background about sort of how we got here from my vantage point in terms of the Affordable Care Act, some of the provisions that are underway right now that would be highly relevant to rural populations, but that are not operated by HRSA, and then I'll speak straight to some of what we have underway with the Affordable Care Act provisions. Let me say, though, by way of background, that much of what prompted, of course, the enactment of the Affordable Care Act were concerns about rising costs, diminishing access particularly to health insurance coverage, of course. Generally, when we're in an audience like this, we're thinking about geographic access. But primarily, the driver was concern about difficulty in accessing health insurance coverage and the affordability of health care and health insurance. And those were issues that impacted and continue to impact many people in North Dakota and people all across the United States. Those were some of the very same problems then that we're facing here being faced in other parts of the country, and that the Affordable Care Act, that law, was designed to address. That is embedded within the law, the aim that every American ought to have access to affordable, high-quality health care. So the law itself was a direct response to what a lot of folks saw as an unwieldy healthcare delivery system, far too frequently fragmented, far too frequently unaffordable for too many people, complicated and expensive. And more specifically, healthcare was rapidly becoming out of the reach of individuals and families. As you saw, the cost of healthcare insurance coverage ticking up, and the ability to afford it for either businesses or individuals and families declining. So the trajectory that we were on was particularly problematic. It was a trajectory that was putting access to health care increasingly out of range of a lot of financial range of families, businesses, and individuals as well. Likewise, we have across the United States compromised in many circumstances, compromised quality. That is, circumstances where we know if there were some changes engaged, we could actually improve quality, enhance care coordination, decrease fragmentation, etc. Lots of examples across the U.S. of wonderful, high-quality care. But that was inconsistent, and frankly, even inconsistent within some hospitals. So in one unit, you might have really high-quality care, in another unit, not so much, and so on. So inconsistent quality, challenges with affordability and accessibility, as I said, all rolled up to putting us on a very problematic trajectory. Basically, we were faced with a health insurance market that worked pretty well for health insurance companies, but didn't always work very well for families that were uninsured or that were losing their health insurance coverage. So lots of people then feeling like their healthcare choices were out of their hands and or didn't have choices at all. Law was passed, obviously, and since that time, in response to some of those challenges, since that time, we've been working pretty much nonstop, I can tell you, to implement the provisions of the law. And while lots of people focus on what's going to happen in 2014 and 2015, in fact, what I'm going to be sharing with you today is a lot of what's already been happening, sometimes without people even recognizing necessarily that a benefit that they're able to participate in is a direct result and wouldn't have existed before the Affordable Care Act. All by way of saying that this isn't something we're all waiting for. There are lots of provisions that are already rolling out, and of course there will be many more to come. What I like to talk about when I'm thinking about the Affordable Care Act, and what I like to focus on, is the area that speaks to me most directly, probably as a nurse and as somebody that comes out of a very rural state. And that is its very intense focus, the intense focus of this law on primary care. Focused like a laser on strengthening the infrastructure to support primary care. That is to prevent illness, to improve health and focus on wellness, and to mitigate chronic diseases and symptoms associated with those diseases more effectively than we have historically. That's not what you hear about. It's not what you read about in letters to the editor, what you hear about on radio talk shows, for example, but that is a central and often overlooked part of this law. And it's a part that I think is particularly important. We see the infrastructure of primary care across North Dakota playing out really quite well when it's there and it's strong, with health care systems that are built off of strong primary care. We see lots of benefits to that, and that is really quite fundamental, foundational, if you will, to much of what's embedded in the Affordable Care Act. But as I said, at the heart of the law, not talked about so much, but very much a part of what we're focused on in terms of the provisions that we're working on. So, and so probably the last point before getting into the what does the law do and what are we working on right now, the last point that I'd make is given circumstances like high rates of chronic illness in rural areas, in sharp contrast to a lot of the myths that people might have who live in urban areas, that rural communities and rural populations are healthier than anybody because they're out there in fresh air, etc. And all of us know that all you have to do is look at the data. Not so. We've got a high rate of chronic illnesses in rural communities across the United States. So when you see a law that's focusing on benefits for elders, high proportion of elders in rural areas, a law that's focusing on trying to catch chronic disease early, so prevent it or treat it as effectively as possible upstream. When you see a law designed to do some of that, you can see firsthand the difference that those provisions would make, even by looking at places in North Dakota that have a good, strong basis, if you will, in primary care. So clearly an important focus, one that's not always talked about. Well, let me get into what the Affordable Care Act has been doing, is doing, and will do going forward. And one of the areas that's particularly important under this rubric of focus on primary care, illness prevention, health promotion, and managing chronic disease more effectively, one of the areas that I think is most important is a focus on prevention. Specifically, there are many provisions that focus on prevention, and the public health folks in this room would be able to speak to a lot of those provisions. Many new programs rolling out of CDC with resources coming right into the state of North Dakota, for example, from some of those programs. But I'll give you just one or two examples of prevention. One of, I think, the most important provisions that's already underway is eliminating out-of-pocket costs associated with screening services. Taking out-of-pocket costs away as a barrier to individuals getting preventive screenings, basic preventive screenings. In fact, last year, in 2011, we had about 86 million Americans that were already taking advantage of preventive screenings with no out-of-pocket costs. Probably didn't even know it, but 86 million Americans already taking advantage of that, of the law's prevention benefits. Some of them, a lot of them, were Medicare beneficiaries, and some of them were people who were enrolled in private insurance plans. But specifically, that elimination of out-of-pocket copays for services like colonoscopies, speaking of, and mammograms and other services, critically important for all the obvious reasons. That is, trying to catch problems early rather than paying the hefty toll in individuals' health and in healthcare costs later on. So removing that barrier that a lot of people were experiencing. Among those people who were able to take advantage of just that one benefit were 75,000 Medicare beneficiaries right here in the state, in North Dakota. So again, people not even necessarily aware that provisions are already rolling out, but about 75,000 people who had to pay no out-of-pocket costs for preventive services, and no out-of-pocket cost for wellness visits with their physicians. About 130,000 North Dakotans on private insurance plans that also gained preventive services coverage with no cost sharing. Moreover, we've got new screenings that are available, will be coming online for women later this year, screenings with no out-of-pocket costs for gestational diabetes, with no out-of-pocket costs for screenings for domestic violence, and for other issues as well. So as you can see then, it's through provisions, very concrete provisions like these, that the Affordable Care Act incentivizes health promotion and wellness, trying to really go upstream rather than just taking really good care of people after they become sick, and instead trying to go upstream and focus on preventing illness on the front end. In terms of insurance coverage, I want to stay with that for just a couple of more minutes to highlight a couple of other provisions that have also come online. Parts of them have already come online, parts of them will be coming online. One of them is pre-existing conditions, and that is the prohibition of insurers from denying coverage to Americans with pre-existing conditions. This is an extremely important provision for people who need coverage, but who couldn't afford it because they had a pre-existing condition and the insurance policy was incredibly expensive to purchase if they could get it at all with a pre-existing condition. So the law removes those barriers to pre-existing conditions coverage for individuals. And in fact, to bridge us to 2014, we have what has been put in place, not by HRSA but by CMS, what has been put in place is something called the Pre-Existing Conditions Insurance Plan, which is right now providing insurance as a bridge to about 50,000 people across the United States who had incredibly serious illnesses, who could not get health insurance coverage, but who can now, by virtue of their paying premiums, obtain more affordable and accessible health insurance coverage. And we have right here in North Dakota over 30 previously uninsured residents. So these would be people with incredibly serious illnesses who were locked out of insurance coverage historically, but are now able to participate in the PSIP program as a bridge to 2014. In addition, in terms of insurance coverage and ensuring that people stay healthy, has been the Affordable Care Act provision that enables dependents up to the age of 26 to stay on their parents' health insurance plans until they reach that age. For numbers of folks, this is a provision that is now added, or now is providing coverage for an additional 2.5 million young adults across the United States who have already, through their parents' plans, taken advantage of that coverage. Lots of them, of course, at that age sort of think they're invincible, and most of them are. That's a pretty healthy population, but you know what? For a lot of parents with kids, those kids in some cases are one illness or one accident away from having potentially hefty health care bills. So yes, it's a healthy population writ large, but individual cases, probably a lot of sleepless nights for a lot of parents while their children were having to go without health insurance coverage. How has that impacted in North Dakota, impacted young adults in North Dakota? We've got about 30,000 young adults under the age of 26 that are enrolled now in their parents' insurance plans as a result of that provision. Has had a very significant impact already right here. And that, of course, is, as I said, while the young adults may not attach so much significance to it, clearly this has got to be peace of mind for their parents at the very least. And also, importantly, when these individuals are coming into the healthcare delivery system, whether into a clinic or into a hospital, they've got an insurance card with them now. No small thing for the providers who serve as safety net in a lot of our rural communities, that people now increasingly have health insurance. And this is also particularly important because historically our rural communities, and especially young rural adults, are one of the highest underinsured populations in the United States. Uninsured or underinsured. When you look at the data by age cohort and geographic distribution, one of the highest rates of uninsurance and underinsurance are in young adults in rural America. So you can, as we think about what is the potential impact of provisions like this in rural communities, not insignificant. Finally, the last point about health insurance coverage, the Affordable Care Act, of course, eliminates lifetime benefits, lifetime caps on health insurance benefits, which relieves a particularly serious burden for people that have got chronic, serious illnesses, maybe undiagnosed until maybe a year ago or 5 years ago, a cancer that was requiring significant resources to treat, and or other diseases that have a very high sticker price attached to them. So it's a benefit, a lifetime, eliminating lifetime caps that most of us in this room will never have to worry about. Never have to worry about, because that's just not what we're, as individuals or families, bumping up against. But there are a lot of people outside of this room that aren't so blessed. And so for those that have diagnoses that are life-threatening and very expensive to treat, this keeps their insurance on the table. It doesn't allow their insurance to come off the table. It keeps it on the table, frankly, when they need it most. And lifetime limits will be banned completely, as this is being phased in, will be banned completely in 2014. But thousands of families are already taking advantage of it. Families with children, for example, are already taking advantage of it, including, I was just on the whitehouse.gov website yesterday. I was looking for something else, and I happened to click on North Dakota just to see what might be up there. And interestingly, there's a family, a young woman in Bismarck, that talks about her child, a picture, a photo of her and her daughter, and the genetic disorder that her daughter has, and how they were within just a few months of coming up to their lifetime cap, and now don't have to worry about that. All you have to do is hear that story to see the difference that, while it may not matter to us in this room, matters greatly to people who are at the verge of knowing that there is a treatment out there, incredibly expensive, $300,000 a year in this case for that child's medications and surgeries, but knowing that there are treatments out there, but knowing that they might be just a few months away from not being able to afford the treatment for a child. It's a pretty compelling case about how important removing that barrier is to some families. Finally, not thinking about insurance coverage specifically just in general, but rather focusing on insurance coverage for medications. As I mentioned, and as all of you know, we've got a high proportion of elders in rural areas, and their ability to be able to manage chronic diseases is critically important. Their ability to pay for drugs, etc., is extremely important. And on that front, millions of seniors that have very high, so those with the highest medication costs, are already seeing savings, decreases in the cost of their medications for those who are in the highest range, with an average last year of savings as a result of the Affordable Care Act of just over $600 per person. So in North Dakota alone, what has that meant? Well, that has meant that about 11,000 Medicare beneficiaries have received significant rebates and savings on their medications to help them cover the costs of their prescription drugs. New data that were just released, not by the U.S. government, but rather by an outside think tank, just recently released about 2 weeks ago, showed that about 5.1 million seniors and people with disabilities on Medicare saved more than $3 billion over the last couple of years as a result of the prescription drug benefits in the Affordable Care Act. So again, those are particularly important stats for our rural Medicare beneficiaries because of their ability to benefit from those cost savings. Meanwhile, there's also the last benefit that I'll mention that is associated with something called the 80-20 rule. And some of you may well know what that is, and others perhaps not. But it's something that some people here in North Dakota and elsewhere across the country later this summer are going to be impacted by. The 80-20 rule basically says that for insurance companies must spend at least 80% of their revenues on healthcare services for the people who are enrolled in their insurance plans, or on improving the quality of care that those people who are enrolled in those insurance plans receive. One or the other, 80%, at least 80% must be spent. And if it's not, then that money, the difference, must be rebated back to individuals and businesses that are paying for those insurance plans. They're obliged, as I said, to spend at least 80% of their premiums on either healthcare services or on quality improvement. And if they don't, they're obliged to rebate the difference to the policyholder. And by August of this year, consumers and businesses across the United States will receive a total of about $1.3 billion in rebates, going back to individuals that have purchased health insurance coverage, but where the insurance company is not meeting that standard. And those estimates come from the Kaiser Family Foundation, projecting that for North Dakota that will mean about 4,500 individuals who will be receiving rebates of some amount. I'm not talking but I am talking about might be $30, might be $50, etc. Whatever it is, actually resources are coming back to individuals. So that just gives you a sense of what's been unfolding already and what's unfolding even this summer. And looking forward, of course, to health insurance exchanges. That is a provision that's being stood up in 2014 to make buying healthcare coverage easier and more affordable. And it's really about introducing competition and choice, something that you don't always see in rural communities when it comes to choosing, having choices for insurance coverage. So as the marketplaces are stood up, for rural health in particular, this will be not insignificant. So for example, if you're a family-run farm or you're a small business in a rural area, people will now be able to enter the exchange with the same negotiating power as large companies have historically had. So it starts to level the playing field, if you will. In a way, it's interesting because big box stores, let's say, without calling them out by name, but large employers have been able to negotiate pretty favorable rates compared to very, very small employers in, for example, small rural communities. Might be asking for about the same type of health insurance coverage, but historically, in a lot of parts of the country, they're paying very different rates. So this starts to help level that playing field, and it ought to be pretty obvious then the difference that will make for rural communities, rural businesses, and families. So far, North Dakota has received about $1 million to begin to do research, planning, IT development, and so on around a health insurance exchange. Starting in 2014, that's when those insurance exchanges will be stood up. And new estimates that were just released within the last couple of months from RAND indicate that about 1.5 million rural Americans who would otherwise be uninsured will gain by 2016 through the expansion of both Medicaid eligibility and the creation of the exchanges. So you can sort of see the path that we're on going forward. And I think with that by way of background, I'm going to skip over and just say there are a couple of other provisions that have come to North Dakota that are just worth a mention, and then I'm going to move right into what we're managing in terms of provisions that have a direct impact on rural areas out of HRSA. In all, North Dakota, and I know you're not all from North Dakota, but if you're from another state, these same issues would be playing out there too in terms of policies and provisions. But in all, North Dakota has received really getting close to about $13 million through the Affordable Care Act to date. In addition to some of what I've mentioned, we've seen about $6.2 million come in to expand health professions workforce in the state. We've seen about $3,000 to come in, so large to small, $3,000 coming in to help enroll and outreach to eligible Medicare beneficiaries about their ACA, their Affordable Care Act benefits. We've seen other provisions flowing resources here. The family-to-family information centers that would be familiar to some of you. The state has been able to bring in about $190,000 in Affordable Care Act funds. That's a really important program that links families with other families that have children with disabilities, have health care needs or educational needs. We know that that infrastructure to help families navigate might be a little bit thin in rural areas, so that family-to-family health information network infrastructure is probably especially important for rural versus urban communities and urban families because of the difference that you often find with regard to resources. So those are some of the provisions that have been supported right here in North Dakota. With that, let me, as I said, turn your attention now to what we're busy involved with at the Health Resources and Services Administration. I'm going to mention just three. And each one of them, of course, would be categories that would be known to each of you. Community health center investments, investments in critical access hospitals, and investments in the National Health Service Corps, so the healthcare workforce. And again, this gets back to a point that I made much earlier, which is investments in primary care and illness prevention and health promotion. In each of these investments, especially the community health center side and the healthcare workforce side, you see the strong focus on expanding primary care. So first, a word about the new investments and expansion in terms of access to primary and preventive health care services in communities through the Community Health Centers program. Health center networks, of course, community health centers, we have some here in this state, we have them in every single state, deliver primary care services, but I'm using a broader definition, not just those traditional medical services that you find in a clinic, in a primary care clinic, but also tend to deliver oral health care services or connect to them, as well as behavioral mental health services. Those are the services that get wrapped up within most of our community health centers. Since the president took office, we have seen the number of patients getting health care through community health centers growing by about 3 million, mainly due to the investment, the 5-year investment that's made available through the Affordable Care Act in community health centers, and then before that, about a $2 billion investment through the Recovery Act back in 2009. And in fiscal year 2011, just last year, we distributed almost, through HRSA, almost $900 million to more than 500 community health centers serving rural areas. So $900 million to rural-focused community health centers across the United States, supporting the expansion of services, investments in quality improvement, really important, and investments in construction and so on. To give you a sense of what those also include, in addition to the categories that I just described, there also have been resources put out to help support planning grants for organizations organizations that are thinking about becoming community health centers as well. And related to community health centers, we also made available last year about $46 million through Affordable Care Act investments to more than 126 school-based health centers in rural areas across the United States. For a lot of our kids, particularly kids coming out of disadvantaged families, coming from disadvantaged families, that locus of healthcare services is critically important, because for a lot of families, it's in school or it's in the emergency room. And there's not much in between. So this investment, we think, is particularly important, putting resources right where the kids are. Available, of course, to all kids that come through the doors, but probably especially important there, and important for that population, and important, too, for school nurses and others who are there and charged with helping to manage chronic illnesses that we see in kids that may or may not be coming out of disadvantaged families. So a pretty substantial investment in school-based health centers, funds then that were used to renovate centers or purchasing movable equipment. I can't tell you, I wish you had the chance to read some of what hits my desk, about a letter from a school-based rural health center in northern Maine that was basically using a janitor's closet both to store things and also to see kids, because that's the best they had, but not anymore. They were one of the successful applicants for some of these funds, and now have 2 exam rooms, for example, not part of that infrastructure, but separate from it, to see kids and focusing on, as I said, keeping people healthy and kids healthy, and then managing their illnesses as well. And letters like that coming from all over about the difference that those investments are making, really building out that infrastructure in schools. Especially important, I think, for rural schools that often have very limited financial support associated with their sparsely populated areas, so not a lot of local resource. On the quality front, I think it's also worth noting that about 80% of health centers in rural locations have made a commitment in 2011 to become patient-centered medical homes. And that means going through all the paces that are necessary to become, for example, NCQA accredited. Really important. So this is about not just access to health care, it's about access to high quality health care. Thus, the resources and the investment in focusing on quality in addition to ensuring access. Finally, the HRSA recognizes that there are frequently tensions in some cases, between community health centers and other healthcare infrastructure. And so last year, we made a very concerted effort to drive collaboration into the applications that were being submitted to the agency for funding and for resources for new access points, for example, and so on. So there's a tremendous more investment in increased emphasis on collaboration in our funding opportunity announcements that we make available to health centers, with points that are allocated against that expectation. New access point applicants, for example, are also expected and asked for letters of support from rural health clinics, from local health departments, from critical access hospitals, and if they don't have them in their application, then they are asked to indicate why they don't have those letters of support for those investments locally, why those letters couldn't be obtained. Collaboration is, at the end of the day, our goal. It's really about trying to maximize efficiency and making sure that all of our investments are working as collaboratively as they possibly can together. And I'll tell you, just as an aside, I had a bit of a fight with the Office of Management and Budget on that very point. They were sort of getting into our business on these new point allocations and why were we driving toward collaboration, et cetera. So the head of our program came in and said to me, "Mary, OMB's not rolling over on this." And I said, "Well, we're not either. We're going to keep pushing forward." So lots of chefs in the mix, but really with an understanding that comes out of rural North Dakota. People and organizations have got to be working together. We don't have the luxury, and I don't think we'd want it anyway, to be operating and infusing resources, except that we're constantly driving toward cooperation and collaboration. So to the extent that you also see opportunities where we should be moving in that direction, strategies we should be deploying, we're always looking for those ideas from the field about how we can enhance that effort, all of us collectively working toward a common goal of ensuring access to high quality care. So it is very much about helping helping people to improve collaboration. That's where we're moving on the investments in primary care and access to preventive health care services through those investments in community health centers. Now let me take you to the second of the third areas I told you I was going to talk about that HRSA is responsible for. We have many others, but I'm just going to mention three unless you've got a question about the others. The second Health Service Corps. And the National Health Service Corps is an incredibly important opportunity for us through the Affordable Care Act to make a significant advance on getting healthcare providers, primary care healthcare providers, into underserved rural and urban communities. So the Corps has placing primary care providers, and those of you, probably almost every one of you in this room is familiar with the National Health Service Corps, in exchange for working for at least 2 years in an underserved area, rural or urban, the National Service Corps will pay down the loans that have been accrued by a primary care physician assistant, a primary care physician, a primary care nurse practitioner, a dentist, an oral hygienist, a psychologist, a social worker, etc. So that's the set of primary care providers as we define them. The Affordable Care Act allocated to us $1.5 billion over 5 years to strengthen the numbers of National Health Service Corps clinicians. And and as you can imagine, a good roughly I'd say probably about half of our National Service Corps clinicians end up working in rural areas or serving rural populations. So this is an incredibly important investment. Think about this, just to give you a sense of how the numbers have changed. In 2008, we had about 2,300 National Health Service Corps clinicians. Of those categories I just shared with you and a couple of others, those categories I just shared with you, we had about 2,300 in the field. In September of last year, because we've been moving on the Affordable Care Act and implementing the provisions, we had 10,000. Think about the difference that access to a dentist makes in a rural community, or the difference that access to a general internal medicine doc or a family medicine doc or a PA makes to a rural community, one by one. I'm from a rural community. It makes a huge difference, huge difference. So that's how our numbers have increased. And I'll tell you, in my lifetime, having been familiar with the National Service Corps for decades now, it's about 40 years old, I would never have envisioned that we would have had a bolus of resources to really make a difference for millions of people across the United States who now have access to a primary care provider. Again, you see that continued focus on primary care, not just building out the infrastructure through, for example, community health centers, but also layering in the clinicians as well. So health professionals now, we've just made a new change in the National Service Corps, and we're giving more resources, more loan repayment to individuals who are willing to go to the highest need areas. So we're really trying to target folks to go out to the highest need areas, up to $60,000 in annual loan repayment. If you go to the highest need areas, $40,000 if you choose one of the lower need areas through the health profession shortage areas. Here was another one that was a funny provision. I had a conversation with folks, this one too at OMB, basically saying, if you build it, will they come? If you build it, if we put these resources in, will that next generation of fresh-faced physicians, nurse practitioners, dentists go? Will they go to underserved communities? I said, yes, absolutely. I mean, did I really know? Was that an evidence-based response? No, not exactly. Which is a little bit risky. But I said, yes, they will. And in fact, the good news is we have got right now in the hopper probably close to 2,000 eligible applicants. Even with these resources, we're not going to be able to fund. It's competitive. It isn't even a question of using every dollar. It's saying, even with these resources, we still don't have enough dollars because the interest has so expanded. So that's the great news, that the National Service Corps is really building a presence in underserved communities across the country. And you might be interested to know that here in North Dakota, we've got 54 folks, National Health Service Corps clinicians, more than 70% of them who are receiving loan repayment awards now as a result of the Affordable Care Act's investment in the National Health Health Service Corps, and a hefty increase by about 25% in National Health Service Corps clinicians in the state just over the last year. So investments that are making a real and a concrete difference on the primary care front. For any of you who are working with students and you want to share the information with them, it's HRSA.gov, and that's where they can go for eligible applications. The last area I was going to mention was critical access hospitals, and I'll just pull out a couple of provisions that benefit critical access hospitals. As probably you know, we've got about 1,300 critical access hospitals across the United States, many of them right here in this state. They are facilities that are the absolute hub of all things healthcare in many of the communities where they exist. So now I've got a question for you. This is another rhetorical question, but for those of you that are starting to drift off, I'm almost done, not to worry. For those of you who are starting to drift off, here's a question to reel you back in. How many, or what percent of critical access hospitals, those 1,300 that I mentioned, what percent of them do you think are located in health profession shortage areas? 10%? 30% located in health profession shortage areas? 20%? 50%? Any ideas?
80%.
Huh?
80%.
What's that?
80%.
80%. You can tell I grew up in the 60s. What? I can't hear anything now. I turned up that volume way too loud. 80%. Okay, I said it was a rhetorical question. She answered it anyway, and she was almost spot on. So two-thirds. Two-thirds of all the critical access hospitals in the country are in health profession shortage areas. Why do you care? Why should you care about that? What difference does it make? Why does it matter? Well, because because critical access hospitals now are eligible to recruit National Service Corps clinicians. Brand new provision. So think about all of those critical access hospitals that historically were standing on the outside of the National Service Corps program, but are now not, are pursuing eligibility. And as of late April of this year, we had about 58 critical access hospitals, not very many when you think about roughly 1,300, but 58 that were already approved, had applied and were approved to participate in the National Service Corps program, to be eligible. And we've got another 76 that are in the pipeline right now that are in the process of applying to be designated as a National Health Service Corps site. So it's an extremely important marriage, if you will, a match, if you will, between an important program and a very important, critically important source of health care in rural areas. So, so that's one important provision. Another important provision and helpful to critical access hospitals is now the availability of something called the 340B drug pricing program. Might be familiar to some of you. This is a program that has historically not been available to critical access hospitals, but as a result of the Affordable Care Act, it is now. It's available to CAHs, to sole community provider hospitals, and also to rural referral clinics. So you see, rural referral centers. So you see the, wrong twice, rural referral hospitals. Rural referral hospitals. So you see the difference then that this provision makes for rural America, making a program that discounts the price of drugs to a facility for outpatient services for the first time now available as a resource to critical access hospitals, and wasn't historically. So we've got hundreds of critical access hospitals that have been coming in since the enactment of the Affordable Care Act to participate in that program. So those are just three of the examples of programs that we're involved with. A last comment that I'd make, a lot of what we're also focusing on in terms of a healthcare workforce, I mentioned National Health Service Corps, but you see new features embedded within the Affordable Care Act that really drive toward care coordination and also drive toward team-based care. Because at the end of the day, it's about ensuring that we are as efficient and as effective as we can possibly be in deploying the resources of all members of the healthcare team. So you're seeing HRSA making investments right now. We'll probably be making another announcement yet this week. Investments in driving toward and supporting interdisciplinary team-based practice, interdisciplinary team-based education, and we've been working with major foundations on exactly that front, as well as organizations like the American Association of Medical Colleges, Colleges of Nursing, the Macy Foundation, and others with that particular focus. And again, through the ACA's emphasis on team-based care, that recognizes that historically we have clearly clearly had gaps between healthcare providers and gaps between sectors of healthcare that patients and their families have too frequently fallen through. So those are additional focuses you don't hear so much about, but they're very much part of this, of this law. Finally, we're also, as an aside, really trying to drive forward on telehealth and telemedicine applications. We're continuing to make those investments and working as closely as we can with CMS. Secretary Sebelius has a very strong interest. Thank you. Thank you to her, because you don't have to make the case, and that helps us when we're dealing with CMS on telemedicine and telehealth. The fact that she has a keen interest in our trying to build that connectivity out even more broadly. So we're moving on that front. Obviously, with technology investments, we're providing, the HHS writ large is providing incentives to providers to help them adopt technology. We've seen 62 new IT regional extension centers stood up across the United States to serve as resources for providers who are taking advantage of the incentives. And that, by the way, those extensions, those regional extension centers, are based on what? The Ag Extension model. So that's where the idea came from. All of us are familiar with Ag Extension Service. Well, that was the model for the IT regional extension services. And interestingly, you might be interested to know that almost 120,000 primary care providers, including 70% of those rural primary care providers in small practices, have already taken advantage of the information available, the tools, the skills, the expertise available through those regional extension centers. So they're building right out that content and information, access to information, as individuals are going through that tough work of standing up electronic health records and so on. Lots of challenges obviously still exist, but efforts underway. Finally, last program that I'll just mention, because it's a nod toward quality. I mentioned quality earlier, but I would also want to mention the Partnership for Patients initiative, which is also an Affordable Care Act effort. Again, Affordable Care Act designed to address issues around affordability, access to health insurance coverage, primary care, workforce, and of course quality. And the Partnership for Patients is really focusing on a nationwide public-private partnership, ACA supported, that's now involving hospitals, physicians, dentists, nurses, pharmacists, other healthcare providers, unions and employers and patient advocates and health insurance plans, all working to focus sharply on improving patient safety. A lot of us have been talking about that area of focus for a very long time, but the goal of the partnership is to reduce preventable injuries that happen in hospitals in particular, reduce those preventable injuries by 40%, saving lives in the process, decreasing hospital readmissions, critically important in terms of costs, and saving hundreds of thousands of people from complications that force them to return to the hospital. So that's the focus on Partnership for Patients, and I'm really pleased to say that there are 28 entities within this state that have already signed on to that initiative, and all states have entities that are participating in it. Well, that gives you a quick or not so quick run through of some of the provisions of the Affordable Care Act, those that we are most involved with. I did just want to mention that in addition to all of that, the President has stood up something called the White House Rural Council. It's highly relevant to us. It's chaired by, it's separate from the Affordable Care Act, but I at least wanted to mention it to you. It's chaired by Secretary Vilsack, the USDA Secretary. We just had a meeting in Washington at the White House with the two secretaries, Vilsack and Sebelius, and with rural healthcare providers from across the United States attending that meeting, about 25 of them, to talk with both of the secretaries about what else we can and should be doing to enhance the economic and the health of rural populations across the United States. There have been some important initiatives that have flowed through the White House Rural Council, rural healthcare specific, but not just, that have become products of that particular initiative, and I'd say look forward to more activities flowing through this first ever Rural Council. Well, that that provides you with hopefully a look at the specific to rural concerns, some of the Affordable Care Act's provisions as we continue to roll those provisions forward. There's no question we clearly have challenges still in rural America. That's a given. That's why you're here. If we didn't, you'd have had it all figured out and you could have stayed home. But that's the purpose of conferences like these, to share ideas, learn about what's new, and try to drive the health of rural communities forward. So clearly we have challenges, but personally I have a high degree of optimism about what's ahead, both for rural families and rural communities, because finally we're making some headway in areas that I think are incredibly important. And we look forward to really measurable improvements in health status in rural communities across the country. And we'll continue from our vantage point, just as each of you do from yours, to ensure that we stay very focused on that aim of making quality, affordable health care available for everyone in the United States, all Americans, regardless of where they live. And the latter is particularly important for rural communities, regardless of where they live. Thanks so much for the opportunity to be here. I appreciate the chance to talk with you about some of what we're doing.